Hello everyone, this is the main screen of our ventilator, that is Drager's ventilator, and I will show you the different parts of this screen. Here we have the control of the different modes. As you can see right now we are on PCSAMV mode, PCSAMV. So we can change modes from the settings over here. We have different kind of modes as per the requirement of our patient. We have control modes. Right now we are on PCSMV, that is the weaning or assisted mode. The control modes are here. This is like this, VCSCMV and PCCMV. So this is the VCCMV, that is controlled mechanical ventilation. This is controlled mechanical ventilation. And we have these weaning and supportive modes, which are used to support the patient's ventilation, not to control the patient ventilation. Okay. All these settings here, we have alarm setting, we have view settings. We will press this and you will see that there will be change of graphs and curves, and if I keep on pressing we will have the volume and pressure loop here. Then we have over here a special maneuver. Let me show you what we have here. Okay, see, we have the nebulization. The option of nebulization is here. Then there are these things. Can you see the manual inspiratory hold? Then we have expiratory hold. And then we have oxygen suction. While doing suction we can press this and it will the oxygen amount of oxygen going to the patient will increase. And then there's manual disconnection. If you want to disconnect the circuit, you have to then opt for this. Then you have to go for this option. Now the important thing is where we use this inspiratory hold and where we use this expiratory hold. These two are very important. Okay, and I will tell you one by one where we can use these. For that, first of all, for the inspiratory hold, you have to focus on this. This is inspiratory peak inspiratory pressure, PIP, also known as PIP, and this is P-Plateau. The airway pressure tells you a lot about the pathological and different conditions undergoing inside the patient's lungs and the patient's airway. It has two components, as you can see. One is the PIP, that is peak inspiratory pressure, and then there is P-Plateau. You have heard a lot about it, and now I have already discussed this in my session, in my PowerPoint presentation, and now I will briefly tell you how to see whether both are raised or only PIP is raised. Because if both are raised, there are different causes, and when only PIP is raised, then there are different causes. We will go there. There is a special maneuvers option we have, and this box will open in the Drager's ventilator. Now we have here inspiratory hold. We will go and press this. As you can see, manual inspiratory hold, touch and hold. So you can touch and hold for 3 seconds, for 5 seconds, and I'm doing this to see the P-Plateau, and I will go here and I will show you. See, that was actually the graph showing the inspiratory hold. It is hold the inspiration for 5 seconds, and it's just showing us that the P-Plateau was 14 and 15 and PIP was 16. So this is not raised, this is 16, this is normal, and this is also not raised, and the difference between the two is also not much. So this is in acceptable range. But what if it exceeds? What happens when only PIP is raised? Let's say it's 40 and it's like 28 or something. So difference between the two is much more, which shows that P-Plateau is normal, that is around 28, and PIP is 40, which shows that only PIP is raised. So the causes will be different. And then there is another scenario in which both are raised. Like let's suppose this is 40 and let's say this is 35 or 36. So difference between the two is very less now. That shows that both are raised. PIP is raised and P-Plateau is also raised. So we have different causes for these two, and that I have already discussed in my session. Okay, now how to see auto PEEP or intrinsic PEEP, that we have discussed in our lecture. I have already mentioned that what is auto PEEP and what is external PEEP. This is the external PEEP. See, 5. As you can see, it's 5 And because of this PEEP, the positive and expiratory pressure, this is not touching the baseline, the zero. It's not going to zero. Can you see? It's above this level. We have zero here, while it's not touching the baseline, because at the end of expiration, there is 5 centimeter of pressure remains in alveoli. So got it? Now, this is extrinsic PEEP that we have given to the patient for the recruitment of the alveoli. Now, what's auto PEEP? Auto PEEP has already been discussed. Now, I will show you how we will see that if patient is having any auto PEEP or not. There's a special maneuver. I will go to there. You can see expiratory hold. This is used to identify if there is any internal PEEP or auto PEEP developing inside the patient's lungs or not. So what we will do, we'll hold it like for 3 to 5 seconds maybe, and then we wait. If there would be any intrinsic PEEP, this will rise, and this will also rise from its, if it was 5, we are giving the PEEP of 5 to the patient, it will raise above that level, showing that there is intrinsic PEEP inside. Let me show you this again with zero PEEP. Now, what I'm doing is, I'm setting it to 0. So now we are not giving any external PEEP to the patient. Okay, I have set this external PEEP to 0 now, just to make sure to see if there is any kind of intrinsic PEEP developing inside the patient's lung. That means at the end of the expiration, some of the pressure is being reserved in the alveoli. That is usually a condition in the asthmatics or COPD patients. So let me show you again. We'll go for the special maneuver. We will hold this again, like for 3 to 5 seconds, and after that we will leave it. We will see there it's not touching the baseline. Can you see? And we have 0.4. So this is the intrinsic PEEP. It is not touching the baseline, which shows that it is the intrinsic PEEP being developed inside the patient's lungs.